Thank you for the introduction, sir, Cindy, and my pleasure to present to everyone Unraveling Alzheimer's Pathogenesis and Exploring Novel Therapeutic Strategies. This would be a two-part presentation. I will be talking about novel therapeutic strategies here in Hawaii and approved therapies and research therapies. And then Dr. Michael Sonson, who is our incoming director for the Alzheimer's Research Unit at Memory Center, will be talking about the pathogenesis. So how did this came about is, we thought this is a really timely and important topics. Consider how now that there are new options available in the last 2 or 3 years, after such a long time, we don't have any disease-modifying drugs. And now that there's options available, when we use them, which are the correct patients? When do we not use them, which are the patients that are high risk or some of the side effects? And our center has been investigating this therapies since 2016, so for over 10 years. So we have probably had over 100, maybe 120 patients on monoclonal antibodies. So we have a little bit of experience that we hopefully can share, and hopefully the community can find helpful, because we think that's kind of important, because sometimes patient would come to me and say that, that they really want this treatment, they want that treatment because, so-and-so say that this is safe, but the fact is that all medications have side effects. We just have to kind of tease out the risk and see where we are, and hopefully from our 10 years of using monoclonal antibodies and from over 10 years of doing it, we hope to contribute something and to the community and clarify a few things. All right. So this is our objective today. Identify what monoclonal antibodies are and when they are suitable for what patients group, what are the side effects, what patients are at high risk, and if they're at high risk, if they're not suitable, what other options is available? Do we just put them on a high risk option, or do we send them to the mainland, or is there any other options available on the island? Not everybody can have the luxury of traveling to LA or Stanford or Mayo. So what other options are available locally? And that's important for our patients. And then Dr. Sonson next month will discuss about the different mechanistic pathway for Alzheimer's. He's a lot smarter than me, so I'll let him do that. This is my disclosure for research funding, and it looks like a lot, including for NIH. But if there's any other sponsors who wants to come and do research with me, tell them to come and talk to me, please. We need more research. We need more research happening in Hawaii. Okay. So Alzheimer's, just covering some basic facts, important. Okay, over 7 million Americans living with Alzheimer's, and it's very expensive. 1 in 3 older adults has Alzheimer's, die of Alzheimer's and other related dementia. I'm going to not waste too much time on this. I want to spend some time. So what are we really covering? This is exciting for a neurologist like me, who have been doing this for over 30 years. For over almost 30 years, for almost half a decade, all we have was the symptomatic treatment when somebody has Alzheimer's. What's exciting over the last 10 years at our memory center is we have been treating people with disease-modifying treatment, meaning that it targets the biology instead of just targeting the symptoms. So there is a difference between disease-modifying therapy, whether it's deceleration or arrest. We don't have anything to arrest, so be very careful when speaking with the patients. We don't have a cure. I'll make sure they understand that. And the best that we can really do is to slow down the progress. And even in proven therapies like lecanemab and donanemab, we're talking about 22%, 18% of slowing progression. So it's not even close to 80% or 90% or 50%. So make sure our patients, make sure we manage their expectation correct. Okay. And what are the different monoclonal antibodies? We have tested lecanemab since 2016, and since aducanumab, which is discontinued in 2024, we have tested aducanumab since probably 2019. So we those are the three big ones, and donanemab was approved since 2024. How are they different? They're all pretty much what we call monoclonal antibodies, and it works at different points in the what we call amyloid cascade pathway. And so the amyloid cascade pathway starts with the APP amyloid precursor protein, and lecanemab, which blocks the first phase of the protofibrils, and obviously blocking it so it can stop going from the oligomer phase to the protofibril phase, because that's when they become insoluble. Okay, and aducanumab blocked the second phase of the aggregation. Obviously we don't have to worry too much about it now; it's no longer available. And donanemab, which is Kisunla that we have right now, actually blocks it fairly late in the plaque stage. Some studies shows that it may be more effective, maybe less effective. So patients ask me which is more effective, which is less effective. We don't really have such a direct comparison. But what we can tell you is that there are different. How are they different? In what ways? Lecanemab initially is once every 2 weeks, IV injection. Donanemab is once a month injection. Lecanemab is switched to IM injection after 18 months. Donanemab, you can actually stop the infusion depending, on some of the amyloid level. So it's still very new. So there's a little bit once a month right now. What we need to understand, donanemab is once a month. Lecanemab, at least when you start, is every other week. Okay. So what are the problems? What are the challenges with using monoclonal antibody? So after infusing over about 100 to 120 patients for the last 10 years, so we have collected a little bit of experience. Experience is not based on maybe 10 patients. I spoke to some other centers. They may have 7 patients, and they said, "I don't have any ARIA." That's great, but I think it's really important to keep in context. When you have such a large number of patients who have gone through monoclonal antibody, you tend to have a little bit better context. We tend to understand which patients are at higher risk. We tend to steer them away from certain therapies, and we tend to cherry pick. You tend to know that, oh, you know what, I had these patients 5 years ago, they went into ARIA, and I know exactly what's going to happen to you. So I would actually recommend against this particular monoclonal antibody. So hopefully we can share that with you a little bit, so to help you navigate that little bit of the maze a little bit better. So what's ARIA? ARIA is amyloid-related imaging abnormalities. It is really related to how the monoclonal antibody affects the permeability, of the blood vessels, leading to ARIA. E is for edema. ARIA H is for hemorrhage. Okay, so there are two different ARIA E and ARIA H. ARIA H could be microhemorrhage, or it could be superficial cirrhosis, or it could actually be cerebral hemorrhage. So it can be different kind of ARIA H too. So if you were involved in clinical trials in the past, there are also certain levels of ARIA. We actually classify them into different stages, different severity. On certain severity, you have to stop. Certain severity, you don't recommend continuing them back. So we are extremely careful about this, monitoring them, and because we already part of the clinical trial doing them. We have a little bit better system to kind of navigate our patients. And for those who had ARIA, be careful in navigating them back to a safe option, okay, if they do have ARIA. So what are some of the patients that are at higher risk for ARIA? Number one is we know genetics plays a big role. For example, in the aducanumab study, patients who are homozygous, E4, Apple E4, the ARIA E went from 20% with no E4 to 64%. ARIA H went from 12% to a lot higher, about 41%. Okay, so that's why as part of the workup for your monoclonal antibody treatment, we do screen ApoE. Okay, so for lecanemab, for example, if you are E4 negative, the chances is 8%, but if you're E4 positive, it just almost doubled to 14%. Okay. For donanemab, it could go from 11% before to as high as 44% of ARIA hemorrhage. So, so you make sure you discuss this risk with your patient. Yes, I'm excited. We have an FDA-approved treatment, but here are the risks. So before we jump into it, let's get your ApoE4. Let's kind of sort it out. Let's discuss your risks a little bit. Okay, so this is just one of the risks. And another question is that your patients may ask you is, how will I know what are the symptoms? So actually, about 90% of the time, patients are asymptomatic. So how do we then pick up the ARIA? It's really through imaging. So remember, when you're doing the lecanemab infusion, after the 5th infusion, you do get an MRI, because that's when you really ramped it up from 5 milligrams to 10 to 15 milligrams. You ramped it up, and that's when the ARIA tends to happen. So most of this ARIA are actually picked up by the MRI imaging. And make sure that your radiologists are trained to do that. So it took us a little bit of training. Radiologists are very proud specialty too. Sometimes if they miss something, they don't want to admit it. But it took a little bit of collaboration. Thankfully, our radiologists have been reading these images for the last 10 years. And sometimes we have to, hey, listen, you missed this, and thankfully, we're a part of the clinical trial, so most of the images get sent back to the mainland to central reader, people who, that's all they do. So we say, hey, you guys missed this locally, let me show you what the central reader are picking up, so make sure that you have a good radiology team. I think things are getting a lot better, but, but like I said, it is truly a learning process for us to become good at picking up this ARIA. So we are very careful, like some patients that with E4, and we know if they have a bad brain, meaning that the brain look very vasculopathic, or almost amyloidosis, amyloid picture. I steer them away from monoclonal antibody. I say, listen, I know your doctors may say that this is FDA, should be the only treatment, but listen, we've been doing this for over 10 years and we have over 100 patients. This is our experience. And you want to go ahead, we could still go ahead, but here are some of the options that I want to give you. But believe it or not, there are some patients who just gung-ho about it, say, you know what, we only want the FDA-approved option. For example, we had a lady, spouse of a physician, actually, whose son was in a venture capitalist on the East Coast and was very resourceful in the healthcare field and got in touch with people doing Clarity trial and was gung-ho and say that I need my mom on FDA-approved option. And fortunately, this lady, which I actually advised her against, because she's E4, and she has a significant amount of small vessel white matter disease on the MRI. Unfortunately, this patient ended up having a pretty bad urea. She actually had hemorrhage, a lobar hemorrhage, and edema, and ended up having seizure. So right now she's on Keppra and ended up having a stroke. So urea is not something that we read about. It's not something that we worry about. We actually do it. We treat them, and unfortunately, if you do enough of them, you're going to see them. But hopefully, that by information sharing as such, with sites that have gone through this, been doing this for over 10 years, we can hopefully reduce the incidence of urea in our population. And we don't exactly know whether this urea population is higher in the Native Hawaiian population, the Asian American population. We tend to have a little bit higher vascular path as well. And this data are very important. So we continue to collect this data on clinical trials. So for these patients who are at high risk for urea, what are we offering to our patients? We are offering them clinical trials, options with less risk of urea. So let's talk about clinical trials for 1 minute. So some patients just say that, I really don't like the fact that clinical trials have placebo, a lot of that. Yes, they have, at least in a lot of these trials, they have at the beginning stages, in the first 18 months, for many of these clinical trials, 50-50. You could be on treatment 50% and 50% placebo. I always tell the patients, but look at it this way. You have been doing nothing about this for years. You've been on 100% placebo for years. What have you got to lose? If you're on 50% placebo and you don't bleed in your brain, that's a good thing. If you go with a high risk therapy, I know that has more than 50% chance of having urea. You bleed in your brain, that's not going to be better than being on a 50% placebo. Will you decline in the period that you're on placebo? Yes, you might, but eventually you get to the part. So what are the what are some of the therapies that we're offering that is a lot safer than the monoclonal antibody? So again, one of the challenges with the urea, why do they get urea? The problem with getting urea is 3-letter BBB, blood-brain barrier. What is wrong with the blood-brain barrier? The blood-brain barrier prevents the medicine, monoclonal antibody, from crossing into the brain. Okay, so we have to give a lot of lecanemab. For example, we give 15 milligrams per kilogram of lecanemab, and only a little bit of it cross into the brain. Okay, so what do they do? So, the trial, one of the trial that we're running is using a technology called the brain shuttle technology. The brain shuttle is a cell-mediated transport that attaches itself. It is IgG1 Fc in the Fc domain. It's a transferrin receptor, and it attaches itself onto the monoclonal antibody. So the monoclonal antibody that they are testing is called trontinemab. It is really a cousin of lecanemab or donanemab, or aducanumab for that matter. It attaches on it, and by attaching to it, it just pulls the monoclonal antibody into the brain. Because of that, instead of giving 15 milligrams as high as 15, they only need to give it up to only about 3 milligrams per kilogram. So here's the good thing. Instead of giving 3 milligrams per kilogram once a day, and it's given only about once a month instead of every other 2 weeks. Okay, and the good news is that so far, none of the patients had urea, whether it's hemorrhage or edema. That's good news. But the other good news that I want to share about so far on the trial of the results of the clinical trial is, so for example, when you look at the reduction of the amyloid proteins by PET scan on lecanemab and donanemab, or the Clarity and Trailblazer trial, it took them about 18 months to reduce the amyloid level from 100% to less than about, to the level of about 20%. So it took them 18 months. Okay, so infusion for 18 months. Then we're starting to see the reduction in biomarker. Would you like to know how quickly trontinemab, because of the brain shuttle technology, sucked the medicine into the brain? Do you want to know how quickly it affected the reduction? It took them only 3 months to see the reduction of biomarker. So that's the other thing that we are excited about. But like I said, it's still a clinical trial that's ongoing. We have about a dozen patients here in Hawaii that have already gone through. We're looking to accept hopefully about another half a dozen to another dozen patients going through. That's really important that we do conclude Hawaii patients in these clinical trials. So challenge number 1 is the side effects of what we have approved. Challenge number 2 is, okay, so all of this monoclonal antibody, donanemab, and lecanemab that's approved, we're working on amyloid, the amyloid cascade pathway. The question is, do we have the right target? Is amyloid the only way to go? What about tau? What about inflammation? What about neuroplasticity? What about neuroprotection? What about metabolism? So there's a whole domain of other different mechanistic pathway that Dr. Sansan is going to cover next week. So here is just a summary of some of the ongoing clinical trials that are different in working in different pathway. So as you know, we've worked on the amyloid cascade pathway for years. As far as I remember, as a resident for over 30 years, we're making minute progress. We're not making that great of progress. When we can make some progress, then we run into area. How do we overcome that? Do we have the right target? So thankfully, we have really thought about this a long time. So we did have several of our local patients that have also gone on to another tau therapy. Let me see if I have that. No, okay. So another tau therapy working on, again, the barrier is, going through the blood-brain barrier, so the tau therapy, we actually had to do intrathecal injection once every 3 months. We had to come in and we actually give the medication treatment through the spinal tap. So most people don't like it, but treatment once every 3 months, it's actually worked pretty well. Really good for patients from the neighbor islands. So we do have several patients that are on this treatment, working specifically targeting tau protein formation. Let me just take you to the other. So the question is, there is also another clinical trials that is ongoing. The question that they're asking is, do we really have the right target? Keep hitting at the amyloid target. Do we need to look somewhere else? Is glucose, for example, energy, bioenergetics, metabolism, is that a potential therapeutic target that we could focus on and explore? Why do they even think that? Well, because when we look at the PET scan, this is not amyloid PET scan. This is glucose PET scan of normal Alzheimer's patient and patients with diabetes. They saw very similar pattern. Patients with diabetes have hypometabolism in the temporal and the parietal lobe, and so does the patients with Alzheimer's have very and glucose metabolism. So diabetic patients have twofold increase of getting Alzheimer's. So one of the other clinical trial that we completed on the EVOKE study using Ozempic, basically. Ozempic, everybody knows, is very popular for weight loss and other drugs, and I know that they're working. And we actually have worked on this for the last 5 years. We have over a dozen of our local patients that have taken Ozempic for Alzheimer's. And even at that time, 5 years ago, I know it just became available oral. Now, back then it was only through intramuscular injection. We have used Ozempic at 3 doses, placebo, 7 milligrams and 14 milligrams once daily for the 3 groups of patients. So here are the results of some of the, so how did it work or did it not work? So here are the results. So up to this is published in 2022. That included some of our local patients. Okay, this is published in Alzheimer's dementia. And even at that point, there were about 8,000 patients on semaglutide, 8,000 placebo. So at the conclusion of the study, there were over 10,000. Okay, so about we were very proud to say that we contributed about a dozen, maybe I would say maybe about 15 patients local this group. And how do you read this graph? Okay, so this is years of treatment, and this is patient event, meaning that they go from MCI to dementia. That's how we measure the primary outcome. So the goal is to keep them from going to dementia stage. So we know that the placebo group and the treated group, the placebo group is at the beginning, year 1 and year 1.5, even at year 2, we don't see much difference between the treated group. Excuse me. Between the treated group and the placebo group, we don't see much difference. But at about year 2.5, we start to see a separation. The placebo group tends to go into dementia a lot quicker, than the group that's been treated. Again, the ideal dose that they found is about 7.5 milligrams per day. And again, so what are the side effects with this pathway? The main side effects are really weight loss, okay, and which happens in about 40% of patients treated patients. Most of them actually not very severe and reversible. We had one older Japanese male who actually lost maybe about 10 pounds to about less than 90 pounds. So he's a small frame, became a really small person. We actually had to reduce his semaglutide dose, and his weight started climbing up again. Unfortunately, the FDA gave a readout on semaglutide last year, and the company Novo Nordisk decided not to proceed with securing FDA approval. For a variety of reasons. Personally, I think they have a lot of things that they're going after, especially the weight loss market, the diabetes market, the cardiovascular market. To them, Alzheimer's is a small market. So unfortunately, it was not approved. I actually tried to prescribe it for the number of patients that were having great results on semaglutide, so which unfortunately the insurance will not cover. Okay, so let me cover this real quick. This is another interesting compound. So the question is, when we look at amyloid and tau, is it just one protein that we're dealing with? When we looked at neurodegenerative disease, when we look at Parkinson's, we have alpha-synuclein. Huntington's disease, we have huntingtin. And we have when we look at prion disease, we have prion. Is this when we have ALS? We have alpha-synuclein. Is this one proteins that we're dealing with, or could that be multiple toxic proteins? And if they are, how are they related? Is there a potential common pathway leading to the multiple proteins toxicity? So it happens that when we looked at all this, excuse me, all these toxic proteins upstream, there's actually a highly preserved consensus loop in the 5' untranscribed receptor of the messenger mRNA in homology. In homology between alpha-synuclein, amyloid, there is actually very similar, more than 50% homology. So because of that, the company called Annovis was able to develop a product trying to block this production of this toxic proteins that are very high, very upstream. Okay. And we were involved in this almost for the last 10 years, involved in the investigation of this product, including phase 1. So now it actually has a name called butanetap. We published this in 2022 in the Journal of Prevention of Alzheimer's Disease. We tend to have a novel translational. Again, it blocks the inhibition of the translation of these multiple toxic proteins at the level of the messenger RNA. Okay, and again, because we're talking about multiple neurotoxic proteins, we actually tested in both Alzheimer's and Parkinson's patients. And initial studies, there is an improvement in the cognitive in the Alzheimer's patient. But to me, anything can improve cognitive. Even Prevagen can do this. So I'm not really impressed. I don't get excited about that. But what I really want to know is, what are the biomarkers? Did it make a difference? Did it reduce the amyloid, reduce the tau? So what was really important is we actually put a CSF catheter in these patients. And after dosing them, we went and sampled the CSF, and there was a reduction in the beta amyloid 40, beta amyloid 42, total tau, phosphorylated tau, APP, amyloid precursor protein, TREM2, YK40, neurofilaments, neurogranular, and that's what really is important, the reduction in biomarkers. So we were really happy about that. And we are still recruiting patients. We have about 40 subjects locally that have gone through this in the last 10 years. And so far, the most common side effects, again, no ARIA. This, the most common side effects, dizziness, 10%, nausea, 5%. So far, it has proven to be safe and promising. The trial that we are offering our patients, and this is a PO, this is a pill that they take, no IV infusion. We do not need a PET scan or CSF. We use biomarker, p-tau217 to qualify our patients. Obviously, we want to know you actually have Alzheimer's, so we just use p-tau217. You're either positive or negative. You're positive, go. So if you go, there's a 50% randomization. In the first 18 months, you could be on treatment or placebo. After 18 months, you're guaranteed treatment. Okay, so they do go into open label. So I let my patients know that you will receive treatment, but just not sure in the first 18 months, you could be placebo or treatment, 50-50. So we're really excited about it. So let me switch gear a little bit. So far we talk about amyloid, targeting amyloid, we talk about targeting tau, targeting glucose metabolism, talking about targeting upstream. What about the patients who already have all this amyloid and tau in their brain? So amyloid, extraneuronal tau inside. So what do we do? Is it too late? Is there nothing that we can do? So the really smart people thought about it for a while. And they said, okay, why don't we just activate the garbage collector in the brain, the microglia in the brain? We just activate that because they can actually go around the brain and start eating up all the amyloid. So they trigger the TREM2, which is a triggering receptor expressed on myeloid cell 2. It's a transmembrane receptor on microglial cells. So basically, it is another monoclonal body. So we have been infusing our patients. We have about several patients here on the island that's receiving this once a month IV monoclonal body. It is actually also tested in ALS. So the premises is we hope that this will actually go around the brain, phagocytosis, eat up all this amyloid. Very early. This is a phase 2 study. Phase 1b study. So we don't have a lot of patients. I don't have a lot of data to share with you yet. Okay. So another thing that we're excited about is, so we talk about different things. One of the things that is really important is neuroinflammation. That's big because we talk about inflammation in cardiac disease, inflammation in tumor, inflammation, this and that. Inflammation is actually gathering a little bit more interest lately in neuro. So how does it work in Alzheimer's? Well, the problem with Alzheimer's is there is definitely a lot of excessive inflammation. We know that amyloid and tau, they get triggered, through the interleukin system, the inflammasomes, basically the smoke detector system in the brain is constantly in the on position. So there's chronic inflammation going on in the brain, triggering the formation of the amyloid and tau. So what do we do? So is it possible that so monoclonal antibody are biologics that we talk about, okay? And then we have semaglutide, which is diabetic pill. Now we're talking about small molecule now. Now, there is a small molecule, doesn't have a name yet, RO7568282. It's a reversible small molecule. It is embedded in the microglia, that acts on the smoke detector in the microglia. So they have created this to selective and reversible block this specific inflammatory pathway by turning off the smoke detector. Very cleverly, it binds and then it turns off the smoke detector, reduce the inflammation. Okay, and this has been worked out in the animal models, in the rat models, and now it is really moving into clinical trials, and we're very excited to start this particular clinical trial later this year. It's not yet started, but I just wanted to kind of pick your interest to let you know that we're working on a lot of things. There are a lot of things. It is not just one thing that we're working on. We're working on treatments that are safer than overcome urea, treatments that think outside the box other than amyloid. Think about tau, think about sugar, think about multiple proteins and inflammation. And we also wonder if this small molecule that works on turn off the smoke detectors, turn it back on the off position, reduce inflammation. Can it actually be used as a combination therapy? Let's say with lecanemab, for example. Do we give patients with lecanemab? Do we give it to? And the nice thing about this is a pill that is going to be on clinical trial. So in the future, my feelings are, Alzheimer's is going to be kind of like treating cancer, treating tumor with a combination therapy. We may have working on different mechanistic pathway. It could be on lecanemab. It could be on a NLRP3 that reduces inflammation. You could be on something that works on tau. It would be a kind of combination therapy in the future. I believe we're moving towards that realm very quickly. I would say in the next 5 years, we're going to really stay ahead of the curve and try to bring as many of this available to our island. We've been doing that for the last 10 years, and we want to continue to do so. And that's really important that we understand that Alzheimer's actually started 20 to 25 years before symptoms. When we get to the symptoms, a lot of times it's very late. We may prevent tau. We may try to remove the amyloid with lecanemab. But what we really want to do is really at this stage, primary prevention. I think so far the best that we can do is doing secondary prevention. But how do we move from doing a secondary prevention to primary prevention? And this is where I think combination therapy is going to be very important. Therapy that really targets inflammation, neuroplasticity, synaptic neuroplasticity. I think those are really going to be important in the coming years. The question, the challenge that really lays before us is, when do we actually treat the patient? So when we talk about treating the patient, most of the time we are really treating the patient here and here. What we should really do is really treat the patient here before the amyloid begins, before the tau begins, before everything begins. So is it possible? Can we do this? Absolutely. We are planning a phase 3 trial, already investigating the brain shuttle trontinemab in patients as preclinical. Preclinical. What is preclinical? Preclinical is defined as no memory loss. Some of you are wondering, who wants to be in a clinical trial if I don't have memory loss? But that is the best place to prevent it, because once you have memory loss, your chances of actually making a difference. It's actually reduced significantly. So this will be a phase 3 multi-center randomized double-blind placebo-controlled testing of trontinemab in cognitive unimpaired patients, looking for patients 50 to 80 years old. There's no memory loss, but you have to be at risk, meaning you have to have at least one E4 and first-degree relatives with Alzheimer's, and obviously positive biomarker. If you're negative biomarker, we're not interested. But if you're positive biomarker, what does that mean? It means that whatever is the process has already begun in the brain. The Alzheimer's has already begun, but you just haven't had enough to show up on PET scan. You just haven't had enough to show up on CSF, or definitely not enough to show up on a neuropsych test. So we're looking for patients preclinical MMSE more than 27, or those with more than 12 years education, MMSE more than 25, those with less than 12 years. So we are really at an era where we want to move into primary prevention. And that's really, to me, somebody who's been doing this doing neurology for over 30 years. This is where I think we're going to make the real difference. And I'm really excited to be part of what these people are doing to really look at preventing the disease, actually, not just treating once the process is already started. So again, when you get tau positive, when you get, PET scan positive, a lot of time, we think it's a process already started, okay? And especially if you actually get memory loss, a lot of times, I don't want to be pessimistic, but I think it's really too late. Okay, so our goal is to really move towards targeting patients who are early, who are cognitive unimpaired, who are at risk, and the process, and even at this stage when they're already biomarker positive. That means your process already starting. Let's work on you over here and over here, and not over here. It's too late. So, all right, what does the future look like? The future looks great. If you're in the Alzheimer's research field, there's currently 164 trials, ongoing, testing 127 drugs. The good news is about majority of the trials that are ongoing, about 80% of them are disease-modifying trial. At this stage, we're not doing any symptomatic trials, but we really need to do much better in disease-modifying trial, whether it is in a biologic or a small molecule, and on average, it takes 13 years average development time. And out of those 127 drugs that is being performed in 2024 year before last, I'm proud to say that our Hawaii team have taken part of at least 10 of those drugs. We were part of, we contributed at least 10 of, and out of almost 58,000 patients worldwide. I'm very proud and very grateful to our Hawaii patients. At least 500 of them have actually participated in this, helping us to make progress, helping us to ensure that progress is being made. So thank you so much. Mahalo to our patients. I want to acknowledge the contribution of our Alzheimer's, memory disorders and Alzheimer's team. This is really a teamwork. Thank you to all the doctors, all the neurologists, the team of neurologists working, and also all the medical students and the clinical research coordinator. Many of them, I hope they are attending the meeting today. Thank you so much for all of your amazing hard work. Without them, we have done many of these clinical trials. So with that, I will finish and we'll take any questions.